Very much, ladies and gentlemen. This is a story about going from study design to record linkage, and the story begins with John Pierce, who was the governor of Edinburgh Prison in 1990, who asked my late husband, an HIV immunologist, and me to come up with a study design that would allow him to know how many of his prisoners were HIV infected, including those who had not been diagnosed, and how they had become infected. The design that we created was called WASH surveillance, W standing for willing, because it needed prisoners' willing participation in order to be ethical, A for anonymous, because there was to be no deductive disclosure about the HIV status of any individual prisoner or indeed about their risk behaviors, S for saliva, because you can test for the antibodies to HIV in saliva, but you very seldom get the virus, and linked to a self-completion questionnaire, self-completion to engender frank answers. The linkage was done by the prisoners themselves. The prisoner was offered a bag in which there were about 50 envelopes and invited to choose one. Inside the envelope, he'd find a pair of sealed labels. Underneath the seal was the same number, but neither he nor anybody else knew what it was. He put one of the numbers around the tube containing his saliva sample. He was chewing on a cotton wool swab whilst answering the questions, and the other on the foot of the questionnaire. The questionnaire was then folded into the envelope, and as the prisoner exited the surveillance area, which was usually the gymnasium, he deposited the salivette, the tube containing his saliva sample, in a big red bin, and the envelope containing the questionnaire in a big blue bin, which came to the biostatistics unit and the MRC's biostatistical initiative in support of AIDS and HIV studies in Scotland. Graham then phoned us to tell us the numbers of the samples that had tested positive for HIV antibodies, and in that way we could identify the risk factors associated with the positive results, but the positive results could not be attributed back to any individual. These studies had prisoners' cooperation. More than 80% of eligible prisoners took part. And the sort of questions on that questionnaire, have you ever injected drugs? 1/3 of the adult male prisoners in Scotland in the early 1990s had a history of injection drug use, and that is still the case. When did you start to inject? Have you ever injected inside prison? Not necessarily this prison, but at any time in your prison career. That applied for half of the injectors. That rate has now fallen because of interventions down to 25%. Did you start to inject inside prison? 10% of the injectors had begun their injecting career during incarceration. Have you ever had an HIV test? About 3/4 of the injectors had had. Have you ever had anal sex with another man inside prison? When they got to that question, there was often a harumph and on to the next. Now, these studies changed the focus of focus on drugs in prisons, but not necessarily to our liking, because very shortly afterwards, the Home Secretary in England and Wales, Conservative Home Secretary at the time, introduced random mandatory drugs testing of prisoners, which meant that in England and Wales, 10% of prisoners would be selected each month and obliged to provide a urine sample to be tested for drugs. Cannabis stays in the urine for 2 to 3 weeks, heroin for 2 to 3 days. And so we warned that this was setting up a new market for the inside dealers, because they would potentially persuade prisoners to switch from cannabis to heroin because they had less chance of testing positive. Also, the price of clean urine went up in the prisons. And so in 1996, when we were doing WASH surveillance studies at Lomas Prison near Glasgow and in Aberdeen, we introduced a pair of new questions asking those who'd been inside prison for at least the past 4 weeks, had they injected inside in the past 4 weeks, and had they used sterilization tablets to clean needles and works in the past 4 weeks. So injectors' answers were that on average they injected 6 times in 4 weeks, and pleasingly from a public health point of view, on average they used sterilization tablets to clean needles and works equally frequently. And so we used these results to argue as follows in a paper in the British Medical Journal. We said, well, if you inject only 6 times in 4 weeks, then you're liable to test positive in random mandatory drugs testing on 18 days out of 28, 2/3 of the time. But, Minister, since you don't actually do random mandatory drugs testing at the weekends, and if our prisoners are sensible, they will organise their injecting such that they can actually test positive on as few days as 9 out of 28. And so who in their right mind would design a measurement instrument, random mandatory drugs testing, that gives you the wrong answer by a factor of between 1.5 and 3? Well, after that, it was a case of, I'm going to wash that woman right out of my hair. Because unfortunately for us, the gentleman in the kilt, Lord Forsyth, who had been the Minister for Prisons in England and Wales, was promoted to be Secretary of State for Scotland. He immediately introduced random mandatory drugs testing of prisoners and banned Graham and me from doing studies in Scottish prisons for 3 years. So that's how I made the transition to record linkage, because it wasn't banned for doing studies on what happens to prisoners after they leave prison. And we had already quantified the mortality of HIV-infected injectors soon after release from prison, a study by then doctoral student Sean Seaman with Ray Brettle, consultant infectious diseases, and me, and shown that there was an 8 times higher risk of drugs-related death in the first fortnight following release from prison than at comparable other times at liberty. But people naturally asked, well, that's for HIV-infected injectors. Perhaps the same does not apply for injectors more generally. And Edinburgh was really the HIV capital for injecting drug users. And so we set about designing a validation study. This is work by Sharon Hutchinson and me. And we set the eligibility criteria: male, age 15 to 35 at release from prison, having served 14 or more days in prison, and it was to be their first release in July to December of any or each of the years 1996, 97, 98, 99. The Scottish Prison Service applied the criteria, and the file which they sent to the Registrar General had the prisoner's name, date of birth, full postcode, release date, and prisoner number. The file which the research team of Bird and Hutchinson received had date of birth, first part of the, had birth year, first part of the postcode, reception and release date, and the prisoner number. They also, the Scottish Prison Service had also given us a variable which we hadn't asked for, which is whether the individual was alive or dead on release from prison, so that we could differentiate deaths in prison from at liberty. And so using the prisoner number, the Registrar General informed the research team about deaths and cause of those deaths within 12 weeks of release from prison. The design assumptions were that these eligibility criteria would net us 20,000 releases. We knew from the WASH surveillance studies that 40% of adult males had a history of injection drug use, and that 20% of the young offenders had a history of injection drug use. We knew also that drugs-related deaths occurred mainly in injectors, and we assumed, unlike in the Seaman study, which was for 1983 to 94, we are now 96 to 99, well into the harm reduction era for injecting drug users. We assumed that drugs-related deaths would occur at a rate of 1 per 3,000 recently released injector days. By recently released, I mean in the first 14 days following release from prison, not 1 per 1,000, which had been the rate in the Seaman study. And the study was the validation study was designed to detect a relative risk of 4, not 8, because as we all know, the first finding can tend to be a random high. And indeed, we netted 19,500 male releases. There were 57 drugs-related deaths, 34 of them in the first fortnight, 23 over the next 10 weeks. And so if that 10-week rate had applied in the first fortnight, we'd have expected 4.6, not 34. So at the end of the harm reduction era, this problem remained massively for injecting drug users being released from Scottish prisons. There's since been meta-analysis that shows that this is not a phenomenon, is not limited to Scotland. They're in England, in the United States, and Australia. So on the basis of the WASH surveillance studies, doing a sort of evidence synthesis, we could estimate that 1 in 200 adult injectors was dead from overdose within 2 weeks of release from prison in a country where there is no death sentence. And so in that paper, Sharon Hutchinson and I had proposed a randomized controlled trial of naloxone on release. Naloxone is the heroin antidote used in accident and emergency and by the paramedics to bring somebody round from an opiate overdose. So the proposal was that this be put in the hands of those who had a history of injection drug use and were about to be released from prison so that they and their friends could reduce the high rate of overdose deaths. It wasn't possible to do that study until 2005, when naloxone was added to the exempt list of prescription-only medicines in the United Kingdom that could be used by anyone in an emergency to save life. It took to about 2008 before we'd passed peer review and got funding from the Medical Research Council. There's a nice story to that. So this is the sort of three musketeers, me because of an interest in drugs-related deaths, John Strang, the director of the National Addiction Centre in London, who had done an amazing amount of work on peer willingness to intervene in the event of an overdose, and Max Palmer, the director of the Medical Research Council's Clinical Trials Unit, to give RCT challenge because I was regarded as an interested party. So the design assumptions for the NALIVE trial: eligibility, 18 plus years, history of heroin injection, and had been incarcerated for at least 7 days. Based on John's work, we knew that someone else is present at about 80% of opiate overdoses. We assumed that our NALIVE workers in the prisons would sufficiently impress upon our prisoners the importance of carrying their naloxone with them, that 3/4 of them would remember to carry it in the first 4 weeks. The carriage rate would drop to about 50% in weeks 5 to 12. Thereafter, it would be lost, tossed, or whatever. And a further dose of cynicism, if you like, or caution. The third assumption was there was a 50-50 chance that that present other would have the presence of mind to locate the naloxone and administer it intramuscularly. And so on that basis, we thought it a priori plausible, if you consider that naloxone has efficacy, almost 100% efficacy, it's what we use. We go down to 80% for somebody else being present, 60% for the naloxone also being present, and then 50-50 chance that it's administered, taking us down to 30% effectiveness in the first 4 weeks, dropping to 20% in weeks 5 to 12. Furthermore, we assume we're now into the end of the first decade in the 21st century, that we would be dealing with 1 overdose death in the first 4 weeks per 200 eligible controls. And putting all of those together, that meant that we were appealing to the Medical Research Council for them to fund a randomized control in multiple prisons in Scotland and in England and Wales, whereby we would randomize 56,000 adult injectors pre-release to naloxone or control. In the control group, 1 in 200 would be expected to die from overdose in the first 4 weeks, so 140 deaths, 30% reduction to 98 in the naloxone group. In the next 8 weeks, we expected a further 35 opioid-related, drugs-related deaths, 20% reduction to 28. Well, you can imagine there was a slight indrawing of breath in the Medical Research Council, and they said no. And then we appealed, and they said, well, maybe. If you persuade us, if you demonstrate in a pilot phase, randomized pilot phase, that indeed 3/4 of the prisoners agree to be randomized, that the prisons come on board, that the prisoners come on board, that the carriage rate is about 3/4 in the first, all perfectly reasonable considerations. So the Medical Research Council funded the first 5,600 randomizations, supposed to be 2,800 in Scotland, 2,800 in England and Wales. And this was the kit that we were randomizing, a wallet. And then the next thing that happened was that in 2010, we were advised by the Scottish Prison Service that their minister, the Minister for Communities and Safety, Fergus Ewing, himself a lawyer, and so no doubt from his legal practice knew the problems of injecting drug users, had thought this was such a good idea that he was minded to make take-home naloxone a public health policy in Scotland. And so the NLIve team wrote to the minister and said, Minister, if you're going to do this, it should be prisoners first, not last, because they're at highest risk. And Minister, if you are going to do this, do not make your outcome variable the number of opioid-related deaths, because these had been on an AIDS-related rising trajectory in Scotland over the first decade of the 21st century. So as many opioid-related deaths, nearly 1,600 in the 4 years from 2006 to 2009, as there had been in the 6 years from 2000 to 2005. And the per annum rate of opiate-related deaths in the first 6 years was 17 per annum in the 45-plus age group, but by 2006 to 9, that had gone up to 43 per annum. So an age-related rise. And this, we thought, was largely because of the aging of the wave of epidemic increase in injecting drug users in Scotland in the early 1980s as teenagers, and this aging through, and that this was the reason for this age-related rise. It wasn't the only reason. Now, what I want you to notice in this, because I'm now going to switch over to a range of record linkage studies, you'll notice that the opioid-related deaths here are, for females, are about 15% of all of the opioid-related deaths. And yet, in terms of problem drug users, heroin users, females are 30%. And so it looked as though the females had a substantially lower death rate than their male counterparts. And Ruth King is in the audience, so the capture-recapture estimates here are joint work with Ruth King and Sharon Hutchinson and Anthony Overstall. And so these were estimates for problem drug users in, well, actually we did the injecting drug users. These are the estimates for problem drug users. But you'll notice that indeed the problem drug users, the females total, is about 30% of the overall total. And when you look at drugs-related deaths in relation to problem drug users, per 1,000 problem drug users, the male rate is increasing with age, the female rate is increasing with age, but at the two younger age groups, the female rate is lower than the male rate, but that female advantage has atrophied by 35 plus. So that the male drugs-related death rate and the female drugs-related death rate when you're over age 35 was the same. So there's an interaction between gender and age group. This on the basis of synthesis of different sorts of data. But this was corroborated, these were data for Scotland, corroborated for England as well. So the similar pattern on the basis of bringing as a numerator the drugs-related deaths and as a denominator estimates of injecting drug users by age group and gender using capture-recapture techniques. So this interaction evidenced by synthesizing data across data sets. So you might ask, why can't a man be more like a woman? Because at least younger women were advantaged in terms of drugs-related deaths. This study in England and Wales of opiate users who had entered treatment at some time in 2005 to 2009 and were followed up to the end of March 2009 was the first to show in, as it were, a cohort study that this interaction was sustained. And so again, in the male rate is much higher than the female rate here up to age 34. It's still rather higher in 35 to 44, but by 44 to 45 plus, the female advantage has disappeared. So it's atrophying with age. we don't know why. Going back to Scotland, it's the problem with record linkage studies. There may be biases that one is not sure about, and so for each of these findings you really want to validate in either new data from the same setting or preferably corresponding data in an alternative setting. And so for Scotland's Scottish Drug Misuse Database, again, that interaction between gender and age group was highly statistically significant. So the next question you might wonder is, why is it that this female advantage is atrophying with age? In Scotland, there was a lot of consternation in the press and also by politicians for the fact that drugs-related deaths in which methadone was implicated were increasing, and they wondered why. So you might say, well, if drugs-related deaths overall, and they're mainly opiate-related deaths, are increasing with age, it's probably not surprising that the methadone deaths are increasing with age. On the other hand, could it be that that age-gender interaction is something to do with the methadone dosing being different between males and females, or different by age? And basically, although this is a prescribed opiate, there were no answers to that question internationally. And of course, a methadone-specific death doesn't actually imply that the deceased had been prescribed methadone, because there is also a diverted market. However, Scotland has a protocol for conducting toxicology at drugs-related deaths. In this, it is in advance of England and Wales. And so Scotland was a good place to look at methadone-specific deaths, by which we meant methadone present, implicated in the death, but not heroin and not buprenorphine, which is the other opiate substitute. And so to tell you a little how we started this was to do the first analysis of Scotland's methadone prescriptions. Now, Scotland has about 500,000 methadone prescriptions per annum, and this is just a comparison between 2009-10 and 2012-13. The proportion of those prescriptions that had Scotland's unique identifier, which they call the Community Health Index, and it enables us to link prescriptions for the same individual. But of course, you need the Community Health Index to be there in order to do the linkage. So the proportion with the CHI present has increased, which is good, but there are still large numbers of un-CHI'd prescriptions. The average number of CHI'd prescriptions for a client for a CHI'd client was 12 to 13. Scotland didn't really know how many methadone clients it had, and how many you estimate depends upon what you assume about the un-CHI'd methadone prescriptions. Either they all belong to the people who had a CHI number, but the prescription simply lacked the CHI number, in which case that lowest estimate would be the correct number. We'd have about 25,000 methadone clients. On the other hand, if you assume that none of the un-CHI'd prescriptions belong to the people who are CHI identified, then you could be looking at nearer 40,000 clients, and it's probably somewhere in between. So we can do linkage only for people who have got a Community Health Index prescription, and so we take the earliest of their index prescriptions in the period 2009 to 2013, link to the deaths register, and find out about drugs-related deaths, and in particular about methadone-specific deaths. And that allowed us to study about 33,000 CHI'd clients and 361 methadone-specific deaths. And so this is just a proportional hazards analysis. And the first thing to notice is that the females do not appear to be at any advantage when you're looking at methadone-specific deaths. The second thing to notice is that the hazard ratios by age, the 25 to 34 age group is the reference group, are increasing very sharply with age, much more so than for all drugs-related deaths. And the top methadone dose, this is the... Sure.
Seems to be 10 years missing.
Yeah,
So 15, 24 and 35 to 44.
Yes, because that's the baseline group with a so essentially the hazard of 1. The others are compared relative to that. Yeah. And the prescription data that Scotland holds are basically for reimbursement of the pharmacists. So they need to know in how many installments the methadone was given out and the total dose of methadone. They don't need to know the methadone dose per day, which is what you do need to do in terms of looking at the quality assurance of the care of the patient. So we could look only at the total methadone dose per prescription for that baseline prescription and divide it into quintiles. And there is some evidence that the highest dose is associated with a higher risk of methadone-specific death. And that's been shown basically in studies, particularly in the United States, for people who have got prescribed opiates for pain. So again, this was a first. And in particular, this very strong age-relatedness was a new finding. So again, you need to try to check it out. And back to Matthias Pearce and Tim Miller and the Drug Data Warehouse in England and Wales, and asking them if we could do the corresponding analysis for methadone-specific deaths within that cohort. Now, the methadone specificity is not as well defined as in Scotland, because in England, what you know is just what's reported on the death certificate as to the drug involved. So although we are here dealing with 130,000 clients, we've only got 271 methadone-specific deaths, but essentially the same phenomenon. No gender benefit for females, and a very strong age-relatedness, much stronger than we've seen anywhere else. And the reasons for that, I'll end with this. This is just pulling the risk estimates for across those two studies. We don't know. One of the adverse events associated with methadone is prolongation of something called the QT segment that you can measure on an ECG, and there are some other ECG configurations called torsade de points, for which being female is a risk factor. We know that dose is associated with a higher risk of QTc prolongation. These patients, the injecting drug users, generally have highly compromised livers from hepatitis C, from their alcohol abuse and from their drug abuse, and potentially also renal compromise. And so if they're not able to clear the methadone as readily as you might expect, then potentially you've got a longer half-life for the methadone and a bigger accumulated dose. And there may be other reasons. So we here have empirical findings from record linkage that have been validated in a different jurisdiction and now require basic studies in injecting drug users to understand why. But in the meantime, we need to warn users and clinicians that although we don't know the reasons for this high rate, the clients need to be alerted to their increasing risk of methadone-specific death as they age, and they need to have naloxone on with them. Thank you, ladies and gentlemen.
Thank you very much. Do you have any questions? You mentioned that you were doing linkage on the chi number.
Yes.
If you didn't have chi number, was there not a possibility to do other, probabilistic linkage or any attempts, or was it only?
It was only done on the chi number. You could potentially do probabilistic linkage rather than exact linkage on the chi number. I'm not sure whether electronically they're able to read. There is obviously a name and address and so on for the patient, but I'm not sure that that is readable electronically. In the same way that on the prescription there is, of course, the prescribed daily dose, but because it's not electronically, it hasn't been read electronically, we can't access it. What we did ask them to, because we were the first people who had asked for the daily dose. They don't base the payments on that, so who cares? And so there is an electronic text, comment text on the electronic prescriptions. And so information on the daily dose would be in there. But also information would be there on the injecting drug user's partner's name, because if he wasn't well, she would come and collect it. And so there was this, identifying information in that text so that they could not release that to the research team, about which I was actually very glad, because I've never done any natural language programming and I'd otherwise have had to learn to do it. And so the Information Services Division in Scotland, who held these data, actually did the natural language programming work, because they could see that it would be of value not just for methadone prescriptions but for a whole host of other prescriptions. And so it was time well put in by them, which it might not have been by us. But that gave us the information on only about a quarter of all of the prescriptions, and only from GPs, not from the other source prescriptions at all.
Not so much a question, just a big thank you. I mean, this is a fantastic application of data science, and I'm very glad I came to this talk. And I just think,
of course, involves many people.
Sure, and you showed that very beautifully as well. Thinking there should be another upshot of that, and that is really bringing into schools knowledge to, how to inject this naloxone or whatever.
The naloxone.
Think of being in the company of a drug user. I wouldn't know what to do.
Yes, that's very interesting. For our N-Alive trial, there is a DVD on YouTube so that prisoners' families could view, know about the trial and understand what randomization was about, and how to fix the plunger into the syringe and also put the needle on, and administer it intramuscularly there or there.
But would you inject heroin or whatever it is in the presence of your family when you've just gotten out of prison? Probably not.
Exactly. And when we went to the prison, Barlinnie prison, which Gillian Rabb will recognise, Scotland's largest prison in Glasgow, and Max and John Strang and I were there talking to the prisoners, and I was explaining about randomisation without using the word to a group of 8 to 10 injecting drug users, and unbeknown to me, Max and John were sitting chortling to themselves as one of the prisoners said, "You mean we'll get it at random?" Okay, good. And then I got my own back on John, because they knew more about the pharmacology of these drugs than he did. So yes, and part of what they said, the reason for the wallet was that they wanted the kit to be as small as a MasterCard, that would fit in their jeans pocket or something. And then John Strang came up with the idea of the wallet. And then we were talking, as you say, about letting the family know. Wouldn't tell my mother. Wouldn't tell my mother. She might think I've gone back to using. Oh no, I'd tell my friends, but I won't tell these big lads. Won't tell my mother. So yes, you're right. It is mostly peers who are present at these overdoses, but quite a lot of injecting does take place in own home or somebody else's home, and so there is the potential for others who are not themselves users to be present and to be able to intervene.
Any other comments or questions?
Thanks very much for the talk again. Can you tell us a bit about the outcome of the trial?
Yes, I wonder if I've got any slides on that. No, I probably don't. Well, so first, I might have. So First of all, let me tell you about the outcome of Scotland's before-after comparison, because the Scottish ministers accepted the scientific advice that they should not use the number of opiate-related deaths as the primary outcome, but instead should look at the proportion of those deaths that had a 4-week antecedent of prison release, because the ex-prisoners were at highest risk, and as you roll out a prevention, you might expect logically that those at highest risk would benefit first. And so in the 5 years before the programme started in Scotland, the National Naloxone Programme, 10% of almost 1,970 opiate-related deaths had a 4-week antecedent of prison release. And these are the data for the first 3 years of the programme. And so by the end of 3 years, Scotland had issued almost 12,000 naloxone kits, just over about 2,300 of them issued by the prisons, and the proportion had decreased to 6.3%. Whereas the secondary outcome, another high-risk period also revealed by record linkage studies, is the 4 weeks following discharge from hospital. But that has not been validated outside of Scotland. It is much less well known by the injector community itself. And so the secondary outcome was a 4-week antecedent of prison release or hospital discharge. And there was 80% power to show a 20% reduction within 3 years. And indeed, the reduction is that. But that is mainly driven by the prison release. And the same has continued in years 4 and 5, for which I don't have a slide. The proportion here has gone down to 4.9, so it's gone even lower, and this has stayed at around 15%. So when the 3-year results came out, they were official statistics in Scotland, which meant that there was a pre-announced release date, and so the Safety Monitoring Committee for the Unalive trial was primed about 3 weeks before these results were due out to consider what actions it would take if the results were as striking as these are. And so we actually did elicitation of prior opinion about what was expected for the 3rd-year results on the primary and the secondary outcome. But we very soon actually had those outcomes, of course, and to me that was pretty persuasive, but it wasn't persuasive to everybody because it is a before-after and Bradford Hill criteria, other things might be confounding and so on. The aspect about which there was no dispute whatsoever by our Data Safety Monitoring Committee was that in Scotland the ex-prisoners could go and be resupplied with a naloxone kit if they had used it or lost it and so on. Those who asked for a resupply on the basis that the kit had been administered, 21 to 5, the administrations were to 21 to somebody else, 5 to them. The corresponding data from the Unalive trial, on the basis of those who'd come back into prison, we had a questionnaire which asked them what had happened to their kit, and the corresponding data were 15-5. So basically a third of the administrations, I think I misspoke for Scotland, it was 21-12. So a third of the administrations only were for the ex-prisoner. 2/3 altruistically were for somebody else who had overdosed. And that meant that the Medical Research Council would be facing not 50,000 but 150,000 releases, even if we could exclude contamination between the randomized groups, which we clearly couldn't because we know nothing about these people, these others. And so the trial as designed, and I was responsible for the design, was the wrong design. We could not go forward to a main trial. You could not get an unambiguous answer. And so we had written into the pilot study and the ethical clearance for the pilot study that if something occurred which made it clear that we would not proceed to the main trial, we would stop the pilot study and the pilot study stopped, the recommendation that we made to the ethics committee and they approved and our principal investigators in the prisons approved was that anybody who had been randomized but not yet released would be offered naloxone on release. That was the impact. We'd randomized about 1,600 at that point.
Yeah, thank you very much.